Hey Mesa, you ready to go?
Yep, I'm ready.
Okay. Well, we will go ahead and get started today. So my name is Tony Ward. I'm a professor in the School of Public and Community Health Sciences. Welcome to our School of Public and Community Health Sciences fall seminar series. We're very lucky to have Walters here with us today. So Maysa will be giving her informational seminar for her PhD program. Before we get started, just a couple of announcements. So this is a co-hosted seminar with Missoula Public Health as through our academic health department arrangement. And we are done with the Missoula Public Health seminars for this semester. So the upcoming seminars are we have Mesa's informational seminar today. We have Tess Carlson, who will be giving her research update seminar on Wednesday, uh, November 19th. So that is a special time and date. So it's Wednesday at noon. And then Tess will be giving her seminar both in person and there's a remote option. So the room will be room 174 for those that want to attend in person. And then there's also a remote link that Nicole has sent out already. And then we have two remaining seminars after that. So the next two Mondays, November 24th, December 1st, we typically reserve those each semester for master's students completing their applied practice experience for them to give their presentations. So for those next two Mondays, a week from today, and then 2 weeks from today, is reserved just for those students in the APE class. So I think there's maybe seven or eight presentations that will be done over those next couple of days. The last announcement I have for today is this Mesa seminar will be recorded. And without further ado, let me introduce Mesa and she can get rolling on today's seminar. So Mesa has joins us from she grew up in Billings, Montana, and she got her Bachelor of Science degree in Population Health from the University of New Mexico in 2022. Mesa also was in our Masters of Public Health and Masters of Public Administration program, where she graduated with dual masters in 2024, and also has a certificate in epidemiology from the University of Montana in 2024. So we're lucky to work with Mesa as both a PhD student, and you'll hear a little bit about some of her work today with her respiratory impacts from wildfire smoke on little kids, but also are thankful that we get to work with Mesa in a more professional capacity through the Center for Population Health Research, where she's a research assistant and working through the Intervention Support Corps. So Mesa helps lots of other research projects through participant recruitment strategies and qualitative analyses, among a whole bunch of other things that Mesa has been involved with. So without further ado, let me introduce Mesa and go ahead and take it away.
Awesome. Let me share my slides. Great. Can everybody see this okay? Thank you, Tony, for the kind introduction. Hi, everyone. My name is Maysa Walters, and I'm a second year PhD student here in public health at the University of Montana. And today I will be presenting on the respiratory health outcomes of children and adolescents exposed to wildfire smoke, a systematic review. Thank you for joining me today. This is my first of my three seminar presentations for the doctoral program, and the aim here is to set the stage for my dissertation research, with this being the informational seminar. This review was recently accepted to the International Journal of Environmental Health Research, and I'm excited to share these findings for the first time since its acceptance a few weeks ago. To provide a brief agenda for today's seminar, I will be walking you through the systematic review from the introduction to its concluding thoughts, addressing the background information, the methods used, results, and conclusions. I have also included a future directions area moving forward in research related to wildfire smoke and youth health as it relates to my own manuscript findings, as well as rationale for my own dissertation research. I'll hopefully leave time at the end for question and answer. So, what do we know about wildfires and wildfire smoke already? Due in part to the ongoing climate crisis, wildfires are becoming more frequent and more severe, both here in the United States and globally. In recent years, record-setting wildfire seasons across North America have taken a major toll on human health and lives. It's not just the intensity that's changing, but the wildfire season in itself is getting longer. For example, in 2023, it spanned from April through October, where in past years, the wildfire season was expected to be from May through September. These changes are driven by several environmental factors, things like early snowmelt, reduced snowpack, prolonged drought conditions, higher temperatures, and increased fuel buildup. Although climate change plays a major role in this, so do human decisions with our environment, like decades of fire suppression policies that have led to an unnatural accumulation of fuel. Together, these climatic and human factors have completely disrupted our historical fire patterns, leading to more frequent and severe fires. And as a result, we're seeing greater impacts on air quality, populations exposed, and public health in general. Wildfire's burden on human health is now recognized as a growing public health concern, especially because it affects vulnerable populations. From past epidemiological studies, we already know that poor air quality in general is linked to negative health outcomes, but what is surprising is how few studies have specifically focused on the health effects of wildfire smoke on children. With our warming climate, smoke exposure is expected to continue to increase, and that means more children are going to be exposed annually. It highlights a real gap in our understanding and a critical need to study these impacts more closely. Health effects of wildfire smoke and particulate matter in general. Wildfires emit a mixture of pollutants, including particulate matter, often referred to as PM. Fine particulate matter, or PM 2.5, is especially concerning because it's 2.5 micrometers in aerodynamic diameter, which means it's small enough to penetrate deep into the lungs and even into the bloodstream. PM10 is another type, but it's made up of larger particles that tend to come from things like road dust or construction, where in contrast, PM 2.5 mainly comes from combustion, so wildfires are a major source. These tiny particles can cause coughing, wheezing, and difficulty to breathe, and long-term exposure is associated with serious health outcomes, including premature death. Globally, it's estimated that wildfire smoke contributes to more than 339,000 premature deaths each year, and this is especially concerning for groups like children, the elderly, and people with pre-existing respiratory or heart conditions. So why are children considered a vulnerable group to the effects of wildfire smoke? They're considered a vulnerable group for several reasons. They breathe more air relative to their body weight, their lungs are still developing, and they tend to spend more time outdoors. Smoke exposure can worsen respiratory health, increase hospital visits, and even impair lung growth and function over time. There's emerging literature that suggests that exposure to particulate matter might affect children's neurodevelopment as well as their overall growth. Another thing that is important to note is that children and youth tend to spend more time outdoors participating in athletic and extracurricular events. For example, if parents sign their child up for a sporting event or extracurricular activity and the air quality is poor, but coach still is holding practice, it is likely the child will still attend practice despite the air quality measures. Being able to better inform individuals who host the practices and parents in general could positively influence respiratory related outcomes. Despite this knowledge, very few studies have focused specifically on pediatric populations when it comes to wildfire smoke, which was a large contributing factor of the aim of this study. So this brings us to the purpose of the study. Our goal was to systematically review and summarize the existing peer-reviewed literature on how wildfire smoke exposure affects respiratory health outcomes in children under the age of 21 years old. Through this review, we aim to identify what's currently known and, just as importantly, what gaps remain in the research. We also wanted to understand whether there's any consensus on how wildfire smoke impacts respiratory health among youth and young people. To guide the review, we used the PICO framework, standing for Population, Exposure, Comparator, and Outcome. Our population includes children, adolescents, and youth under 21 years old. The exposure is particulate matter, particularly PM2.5 and PM10 originating from wildfire smoke. Our comparator of interest was populations not exposed to wildfire smoke or those experiencing baseline air quality. And the outcome of interest is both acute and chronic respiratory health effects. For this review, I searched PubMed and Web of Science for studies published up to September of 2024. We focused on primary epidemiological studies that looked at wildfire smoke and respiratory outcomes in children and adolescents. The review followed the PRISMA guidelines, which help make systematic reviews more transparent and reproducible. And as you can see in the PRISMA flowchart here in Figure 1, it shows how studies were screened and selected, which I'll get into further in the inclusion criteria. The search combined keywords related to wildfires, respiratory health, and pediatric populations. And I did not restrict by date or study design, so we could capture all relevant work. The exact search terms are listed in Table 1 here in the next slide. So study eligibility criteria. Again, we reviewed peer-reviewed primary research publications on wildfire smoke and pediatric respiratory health. Articles reporting research on human health and wildfire smoke were reviewed. To be included, research needed to independently describe a population between 0 and 21 years old. Exposures were characterized as specific exposure to smoke produced by wildfires. Measures of exposures were direct, utilizing existing data from local air sampling devices, or indirect through satellite imagery. And exposed populations were determined by postal or zip code, county, or address of residence. Outcomes included emergency department and urgent care visits, self-reported medical questionnaires, measure of lung function, asthma control, non-urgent clinical visits, and overall respiratory symptoms. Studies were excluded if they investigated non-smoke related morbidities. They exclusively reported pregnancy and birth-related outcomes, as well as if they were outside of the United States and Canada. Studies outside of the United States and Canada were excluded due to differences in wildfire exposure patterns, healthcare systems, and environmental monitoring practices being different, which could limit comparability and generalizability to the North American context. Studies that focused on non-smoke related outcomes were excluded, given that the aim was to report respiratory health outcomes following a wildfire smoke exposure. And then lastly, studies that were included for study designs included observational studies, including retrospective cohort, cross-sectional, and case crossover. All studies underwent title and abstract screening for relevance to the topic, and then followed by a full text review. If duplicate studies were presented, the most recent article was used, and the remainders were then excluded. For study selection, we independently reviewed all records using a predetermined inclusion criteria, which I just went over. We focused on the primary epidemiological studies that looked at wildfire smoke and respiratory outcomes in children. From each study, we collected details on the study and population characteristics, exposure measures like the number of smoke days, PM2.5 and PM10 data, and satellite imagery, as well as health outcomes, including symptoms, clinic visits, and hospitalizations. We did not exclude studies based on the type of vegetation burned or geographic area, for example, number of square miles, as long as they measured wildfire smoke exposure. However, studies were excluded if they did not track particulate matter, in addition to having a clear wildfire smoke exposure assessment, for example, satellite imagery. Study selection happened in 3 stages: title and abstract screening for relevance, a full text review, and then finally exposure assessment screening to confirm that there was particulate matter being measured, as well as smoke data from a wildfire. No automation tools were used, and all screening was done manually by an independent reviewer. To assess study quality, we evaluated risk of bias for each included study. This was done by the primary investigator using the Cochrane guidance to help judge bias across several domains. Risk levels were categorized as low risk, probably high risk, and high risk of bias. We also followed the navigation guide methodology, which includes 4 steps. Those include specifying the question, selecting the evidence, rating the quality and strength of the evidence, and grading the strength of the recommendations. And in total, we assessed 9 bias domains, including recruitment strategy, blinding, exposure assessment, outcome assessment, confounding, incomplete outcome data, selective outcome reporting, and conflict of interest, and then additionally other factors that could introduce bias. For analysis, to summarize the overall direction and statistical association across studies, vote counting methods were applied. For each study, we recorded the effect of wildfire smoke on pediatric respiratory health outcomes for each variable. Effect estimates range from odds ratios, relative risks, incidence rate ratios, or percent change of PM 2.5 or PM 10. And then statistical significance was assessed using the study's reported 95% confidence intervals. For each variable, analyses cast a vote for a positive, negative, or non-significant association, and vote counts were then tallied to provide a descriptive summary of the consistency and reported effects across studies included. The analysis is then repeated for all respiratory health outcomes of interest. And vote counting methods provide an insightful starting point to systematic assessment of studies within public health research. However, it should be noted that it was just a descriptive summary. So our search results identified 120 studies. After duplicate removal, 105 were then reviewed. After title and abstract screening, 94 of the 105 studies were excluded. 13 of those studies underwent full text screening. And from there, 1 study was excluded due to no respiratory or healthcare outcomes. 3 were excluded due to no pediatric data. 1 was excluded due to studying 2 variables on respiratory health outcomes, looking at both BMI and respiratory health related to wildfire smoke exposure. 1 was excluded due to seasonal extreme temperatures, and 2 solely looked at particulate matter to define wildfire smoke. 5 studies were then included in the overall review. In the 5 included studies, all were published between 2006 and 2021. All studies were conducted in North America and most focused on a single city or county. The cities included Calgary, Alberta, San Diego County, California, Southern California, but specifically the San Diego County area, and then 2 came out of the Denver, Colorado area. Together, these studies covered data for over 1 million children under the age of 21 years old. None of the studies evaluated preschool-aged children separately, which was an important gap in the current research. One of the earliest studies by Kunzli and colleagues followed a pediatric cohort of children aged 16 to 18 years to examine symptoms during the wildfire smoke exposure, while the 4 remaining studies relied on population-level data, mainly looking at respiratory-related emergency department visits or hospitalizations. Across these studies, both urban and rural populations were represented, giving a broad picture of how wildfire smoke affects children's respiratory health in a variety of settings. Looking at the data sources for exposure assessment, or study characteristics. Looking at our data sources, most studies, 4 of the 5, used medical or government databases to capture health information. The remaining study, again, the Kunzli study, used self-reported survey data to collect symptoms for information directly from participants. For outcome measures, 2 studies identified respiratory outcomes using ICD-9 or ICD-10 codes, and 1 study used the chief complaint from a medical visit alongside a diagnostic code. 1 study focused on lung function and asthma control using tests like the FEV1 and then the asthma control test. In terms of primary outcomes, 3 studies looked at emergency department visits, 1 focused on hospitalizations, And again, the Coonsley study reported self-reported respiratory symptoms. Across all studies, the most commonly reported diagnoses were asthma, bronchitis, bronchiolitis, pneumonia, and upper respiratory infections. So overall, while study designs and data sources varied, they all pointed toward the respiratory impacts linked to wildfire smoke exposure among children, which was our overall question. In terms of exposure assessment, the studies varied quite a bit in how they measured wildfire smoke exposure. While most used particulate matter, it primarily came from PM 2.5 for 4 of the studies, with one using PM 10 as its main exposure. These measurements typically came from local air quality monitoring networks run by government or environmental agencies. And several studies compared wildfire-related PM 2.5 to PM 2.5 from other sources like traffic or industrial pollution, which allowed them to directly compare health effects from wildfire smoke versus other pollution sources. Many of the studies used satellite data to identify smoke plumes or wildfire events, while one study used meteorological conditions and fire count data to help confirm wildfire activity. Exposures were reported as daily averages, but the lag times, meaning how long after exposure health effects were measured, ranged quite a bit, from same-day effects to as long as 33 days later after a wildfire smoke event. One study even looked at 3 days prior to a smoke event to see if symptoms appeared early, which I found interesting. Across all studies, the most common outcome reported was emergency department visit and hospitalization for respiratory conditions, followed by asthma-related visits or self-reported respiratory symptoms. The studies used a variety of statistical models to analyze the relationship between wildfire smoke exposure and respiratory outcomes. The most common approaches were Poisson regression and mixed effects models, which are well suited for time series or repeated measures data. Others used ordinary least squares panel regression, multi-level logistic regression, and conditional regression, depending on the data and structure of the study design. The outcomes modeled included emergency department visits, hospitalizations, asthma exacerbations, respiratory clinic visits, lung function, asthma control, and self-reported symptoms. Across the studies, models generally controlled for meteorological factors like temperature, humidity, as well as temporal trends. And many also included a fixed or random effects to account for confounding and differences between location or time periods. While the modeling approaches varied, they were consistent in aiming to isolate the health effects specifically attributed to wildfire smoke exposure. Across the 5 studies, the most frequently reported outcomes were emergency department or urgent care visits for asthma, and this was reported in 4 of the 5 studies. Any respiratory symptom was reported in 3 studies, and several studies looked at both asthma and general respiratory outcomes, while outpatient clinic visits were only noted in 1 of the 5 studies. Interestingly, although studies examined wildfire smoke effects on asthma, only the Stoll article reported a statistically significant positive association with asthma and emergency department or clinic visits. The Moore study showed that when wildfire smoke days were compared to clean air days, children were 13% more likely to go to the emergency department for an asthma exacerbation. While looking across all studies, there was consistent evidence for positive associations between wildfire smoke exposure and worsened respiratory outcomes. The Coonsley study examined this by showing that looking at 30 outcomes, 20 had a significantly positive association using measures like fire smoke smelled and PM10 contrast, which does account there. We look at that in terms of biases later. The Aguilera study found a significant increase in cough with wildfire PM 2.5 exposure, though other outcomes like wheezing and asthma were not statistically significant. The Lipner study looked at lung function and asthma control, and while odds of well-controlled asthma were lower after wildfire smoke exposure, the results were not significantly statistically significant. And lastly, the Stoll article identified a positive association for asthma and composite respiratory disease, but bronchitis and upper respiratory infections were not significant. Overall, wildfire smoke exposure is most consistently linked with acute respiratory symptoms such as coughing and wheezing, while effects on chronic conditions like asthma and bronchitis were more variable, likely due to differences in study design, exposure, measurements, and population susceptibility. Looking at the risk of bias assessment, this was done by an independent reviewer. Two of the studies were at a high risk for bias population representation bias, including the Lipner and Coonsley study. Coonsley also had blinding-related bias and potential misclassification because of exposure being self-reported, whereas the Lipner study had some exposure measurement limitations with less precise estimates of wildfire-related PM2.5. Outcome assessment was a probably high risk in the Coonsley study due to self-reported asthma symptoms, whereas 3 studies had probably a high risk from unmeasured confounding. This included the Moore, the Lipner, and the Coonsley studies. Finally, Coonsley also had attrition bias because of low follow-up response rates, which was a concern by including it. Overall, while some methodological concerns existed, all 5 studies were included in the review and provide valuable insight into wildfire smoke and pediatric respiratory outcomes despite having some bias. So, some discussion points. Overall, the evidence shows that wildfire smoke exposure is consistently associated with increased respiratory symptoms in children. The most common outcomes observed across studies included an increase in emergency department and urgent care visits, an increase in hospitalizations, an increase in use of respiratory medication, and an increase in coughing, wheezing, and respiratory distress among non-asthmatic children. Interestingly, studies did not find a significant association between wildfire smoke and asthma-specific outcomes. And reasons for this could potentially be that children with asthma often take precautionary measures, such as using medications proactively, staying indoors, or wearing masks during wildfire smoke events. So while wildfire smoke clearly impacts acute respiratory health, its effects on chronic asthma outcomes appear more variable, likely reflecting both, again, behavior changes and potentially study designs. Some key highlights from the findings. Again, as mentioned, the Coonsley study did report looking at 30 respiratory outcomes and finding that 20 were significantly positive. Notably, dry cough had an odds ratio of 3.35 and wheezing was 3.53, making them statistically significant. However, again, it's important to note that this study relied on self-reported data, which may introduce some bias to these results. The Aguilera study found a significant increase in cough with wildfire PM2.5 exposure, but other outcomes, including asthma, again, were not statistically significant. The Moore and Stoll study reported elevated asthma-related outcomes, but they weren't statistically significant. It should be noted that the statistical findings among the included studies should be interpreted with caution, as there was considerable statistical uncertainty and variability among the included studies. A lot of them had very wide confidence intervals and often included the null. This could be in part due to differences in exposure methods, sample sizes, and populations. It's important to remember that statistical significance does not always equate to clinical significance, so though they might not be showing statistical significance, it doesn't mean we shouldn't care about them. Null or mixed results may indicate clinically meaningful effects, but it just is undetected due to limited sample sizes or exposure misclassification. So looking at the populations, 4 of the 5 studies focused only on pediatric populations. The Stoll study included both children and adults, whereas the Coonsley study analyzed age-specific subgroups. Younger children didn't show significant changes in lung function in the Coonsley study, whereas older children showed below normal lung function after wildfire smoke exposure. Because most of the studies didn't separate age groups, our ability to draw conclusions about different pediatric age responses is limited. This highlights a clear need for more age-stratified research to understand how wildfire smoke affects children of different ages, because as we know, their developmental stages could be very different between a 1-year-old and an 18-year-old. So, reviewing some of the strengths and limitations from the work, the review followed the PRISMA guidelines, which helped ensure a transparent and reproducible systematic approach. There was detailed protocol, clearly identifying how the study was conducted and outlining the review in general. The literature search was comprehensive and was carried out by an independent reviewer, which reduced potential bias. And that same reviewer also completed the screening and risk of bias assessments, helping maintain consistency across the process. Limitations to note included that the review did only look at 2 scientific databases and only included 5 studies, which limits how broadly we can apply the findings. All 5 studies were based in North America, so results might not reflect other regions with different wildfire conditions or additional healthcare systems from both the United States and Canada. Having just one reviewer, although it was noted to be a limitation, could also introduce some bias and subjectivity. And there was a lot of variation between studies in terms of populations, methods, and timeframes, making it hard to directly compare the results. Many studies had wide confidence intervals, showing uncertainty around some of their estimates. And then, in addition, because of time constraints, the review relied solely on vote counting methods rather than a full meta-analysis, which limits the depth in statistical insights. Few studies focused only on children, and even fewer broke them down by specific age groups, which is important since health impacts can differ by developmental stages, as noted earlier. And then lastly, finally, most studies examined short-term respiratory effects, leaving questions about long-term outcomes. And this is an area that could potentially be researched moving forward. So some findings from this review highlight a key need for future areas of research. First, there were many challenges in understanding the health impacts of wildfire smoke, especially in children. However, more observational studies are needed to understand how short and long-term respiratory outcomes in youth are impacted. A key highlight for future research is exploring how respiratory effects differ by age and developmental stage, therefore stratifying research by age groups. A second need is for a conducted meta-analysis and future reviews. This likely will provide stronger evidence by weighing study quality and sample sizes. Though the descriptive review was beneficial for some of our findings today, a meta-analysis would likely help guide interventions and reduce exposure among the sensitive population even further. Many gaps exist within the geographic and exposure assessment with the current literature that exists. So most existing studies were conducted in localized regions of the United States, and therefore larger scale and international research is needed to identify communities most at risk. An area for consideration would be to broaden our exposure measurements and how we do that. So nearly all studies relied on PM2.5 as the main exposure measure, often supplemented with modeling data. However, inconsistent exposure reporting across studies made comparisons difficult. So a need would be a universal reporting system. And then in addition to that, none of the studies looked at indoor air quality during smoke events, although that's where most people spend their time. So adding an indoor and outdoor component could be beneficial for future research. And then lastly, advancing our air quality monitoring as a whole could benefit our understanding on the impacts of air quality on health, both in vulnerable populations as well as in general populations. So currently there's been a rise in low-cost air sensors like Purple Airs, and it's improved real-time smoke monitoring, but these tools have filled important gaps, but they also leave a lot of room in terms of accuracy and consistency. So they don't match our regulatory grade equipment. So improving our equipment and making it standardized, validated, and reporting protocols across all sensors could really benefit future research. Obviously, in an ideal world, a universal monitoring framework would be the gold standard, but that will probably take years to come. So looking ahead, there are several important directions this work can grow, specifically related to my own dissertation research. First, I would like to utilize the already existing Montana DEQ Purple Airs in Schools project. This would allow us to better understand the relationship between indoor and outdoor air quality trends across Montana. So this project has deployed purple air sensors in Montana schools in collaboration with the University of Montana. So UM has sponsored an indoor sensor where DEQ has sponsored the outdoor sensor, and it's a statewide uniformed monitoring system. So it's kind of addressing the gaps that I just mentioned. Being able to incorporate that into my own dissertation research and look at the gaps would be ideal. An additional direction I would like my research to consider is building upon the Research Education on Climate Change and Health program, as well as the Public Health in Schools initiative. These programs have spent so much time going into schools educating children on the impacts of climate change and what public health is. But what I would like to understand is how climate and health education influences their behavior and perceptions. As we spend a lot of time doing these educational classes, is it changing their behavior in any capacity? This would include looking at how hands-on exposure to monitoring equipment and climate lessons shape students' understanding of smoke and their sense of risk and protective actions that they're willing to take both in and out of school. That's one of the many challenges is being able to identify their perception and what they do outside of school when the wildfire season is during the summer months becomes very challenging. But this area could allow for a qualitative component to my dissertation research by having students participate in focus groups and to gain a more thorough understanding of their perception of climate change and the impacts of wildfire smoke on their health. I think by adding a quantitative and qualitative piece, the two directions would help us connect the environmental monitoring and quantitative aspect of research with a more personalized qualitative piece by getting to know and understanding their perceptions of climate change and wildfire smoke on health. The goal would be to ultimately better inform schools, communities, parents, and children, and allow youth to have some autonomy over the decisions they make during a wildfire smoke event. So that concludes my presentation. I can now open it up for questions, but first I would like to thank you all for joining me today, but I would especially like to thank Dr. Tony Ward. His guidance on this project made it all possible, and yeah, I can't thank him enough. So thank you all.
Wonderful job, Maysa.
Thanks.
Do we have any questions from the audience? Either put it in the chat or just show your face and fire away. While we're thinking of questions, Maysa, I'll go ahead and ask one. So, oftentimes in university settings, when we think about communicating results of studies and research findings, we think about like other academics or publishing papers or going to conferences to present. But a lot of the information that you presented could be used to inform, schools or health departments. And, if there's smoke events coming up, should kids practice things like that? So can you talk a little bit about like how could your data be used to inform like more of the practice side of public health in
Yeah,
schools?
I think like one way to doing there's like a big gap between what researchers often do and again like you said just talking to the general public. And so I think of like me as a soccer coach, I'm working with an entire soccer club who practices over the summer months. So just explaining that information at maybe a less academic level for them to understand would really not be that hard. I think of like informational brochures. We have so many connections with our own local communities that um, being able to reciprocate it into a or regurgitate it into a way that people can understand is wouldn't be too difficult and wouldn't take that much time. I saw a question in the chat on why was the population studied, specifically those under 21, and why was this age selected? I had a feeling that this was going to be a question. So for most of the studies that you look at are going, there's like a range. They either look at 0 to 18 years or they'll go 0 to 21 years old. And by not including 21, it was going to only allow like two studies to be included for one. But also, I think of like from a developmental stance, people aren't done developing at just 18 years. So being able to include those individuals into the study was really important to me. But also from a personal stance of working with the high schoolers, if I cut the deadline off at 18 and considered them children, we were going to miss a whole group of potentially seniors in high school that couldn't partake. Like this information might not be as relevant to them.
Then you had another one in the chat. And Allison, let us know if you have one more information on Mesa's response. So Lauren had a question in the chat, Mesa.
Okay. Dr. McCaig said, you noted none of these studies included early childhood preschool. How would you anticipate the outcomes for this younger crowd being different or not from the findings related to the adolescents? Um, I'm going to be honest, have, I don't know enough about the impacts on infants compared to adolescents to answer the question. I would say I would hypothesize that it was younger children may be impacted more greatly, but I know there has to be literature out there. So, Dr. McCaig, I can get back to you on that and do some research after this.
Thanks, Lauren. Any more questions from the audience? Jim?
Hey, Tony. Nice job, Mesa. That was really awesome. I know this will surprise you, but I'm asking a question about the portion of your study that might be qualitative or mixed methods. Can you say anything about what that would look like at this point?
Yeah, I can give a brief where we think it might go. It's definitely still tentative, but many are aware I mentioned the REACH program. And so we have a connection with teachers, primarily in the high school and middle school age, where we can work with them. And my ideal vision would be to provide them information from my second aim, which will be looking at the indoor and outdoor air quality data with purple airs, and provide them like an at-home sense of like in Montana, when there is a wildfire smoke event, this is what I can expect to see outside, or even at a smaller level, doing it for that school individually. Like if Hellgate is participating, I could look at their indoor and outdoor data, come up with it, write them an analysis, and present the findings to them. I would like to follow that educational intervention up with a knowledge, attitudes, and behavior survey. So provide them a CAB with a pre-intervention survey, educate them, and then follow up with a post-survey CAB, but give them the summer months to see like over the summer, did your perception of wildfire or your behavior during a wildfire smoke event change? So that would allow for some qualitative, but the focus groups would then recruit some students who were especially interested in it and just gain like, how would you like to learn? How does like monitoring equipment and hands-on equipment help you learn? And then how do you change your behavior and what is your perception after this educational intervention?
Awesome. Thank you. And one just quick follow-up. Would you see interaction between the qualitative and quantitative data in kind of a mixed methods way, or would they be kind of two different discrete studies, or maybe you're still figuring that out?
Right now I have them as two discrete studies, but it's definitely not set in stone, so I would be open to doing a full mixed methods.
Awesome. Thank you, Mesa.
Yeah,
Nice job.
thank you for the question.
Hey, any other questions for Mesa? Going once, going twice, going three times. All right, Mesa, we'll take you off the hook. Excellent job.
Thank you.
Um,
Thanks for
Please
joining me.
help me in thanking Mesa. All right. See you guys.